period. Welcome to the Topics in Geriatric Health Literacy Active Learning Series. This is session 4. And my name is Tony Denuzzo, and I'm director of the East Texas Geriatric Education Center. And it's good seeing some new faces, too, here for this session, as well as some returners, repeaters, I guess they're calling them, too. But the East Texas Geriatric Education Center is funded by HRSA. We're finishing up our second year, and we're looking forward to our third year with some new activities that we'll be doing. The major purpose of the ETGEC is to provide enhanced geriatric education programs for targeting health professionals. We target all disciplines and also students in health professions. We have partnership with the East Texas AHEC, which has been really valuable with us connecting to our target area, which consists of 60 counties in East Texas. And so it's a large area, and we're really out there trying to promote geriatric education. Today's session is called Breaking Bad News. It doesn't always mean end of life, and we're going to talk more about that in a little bit. We have an agenda here, and you have handouts, so these slides should be in your handout if you need to follow along. Dr. Grumbles is our moderator and main speaker today, and I'll give you a little bio on her in a little bit. But she's going to be taking care of this part with the introduction and what is bad news and some group discussions. We have a DVD we'll look at, so there's going to be a lot of interactive activities going on today. We'll have a short break around 1:30 or so, and then we're going to have role-playing exercises. We're going to have standardized patients come in from our standardized patient program and do some scenarios regarding communication between patients and health professionals. Okay. So. Just have a seat anywhere, please. All right. And after the group sessions, we'll have a little bit of time for everyone to complete their evaluations, which is going to be really important for us to be able to improve future programs. This series is a part of 5 sessions, and we're in our 4th session. And we've started this as a major objective of the ETGEC to bring out aspects of health literacy and what that is. These are very basic sessions in terms of information that we're giving, but I think that we've been able to provide a lot of the basics, and we're really looking forward to providing an advanced program next year. Our final session will be in June 17th, and that's going to look at the role of interdisciplinary teams in health literacy as we have panel discussion, as well as looking at cultural diversity as a factor that can affect communication and health literacy. We teleconference to 5 sites, and I'd like to introduce you to those sites. There you are. Baylor University in Waco, right here. Right? Okay. I believe that this is Pecan Valley in Victoria, right? Okay. They're waving up in the upper right corner. I think that this is Lamar University. Now, maybe people haven't shown up yet, but that's Terry Dickerson with the Coastal AHEC. We're hoping we'll get some more people there. And like I said, this is Stephen F. Austin here. So Baylor, Pecan Valley, Victoria, Stephen F. Austin, Nacogdoches, and Lamar University in Beaumont. And that's how it's going to be set up when we have our discussion for the role play. Okay, moving along. We offer continuing education credits for medicine. I'm going to get to and so continuing medical education we have approved for 3 hours. Main thing is to sign in and complete the evaluation form and hand that in at the end of the session. Just to let you know that these, the CME are given as a cumulative number of Cs at the end of the 5 sessions. So you'll get whatever you have participated in, and we get your evaluations and sign-in sheets. You'll get a maximum of 15 hours CME if you would attend all 5 sessions, and that will be after the June session. That's what the contact. And we also provide continuing nursing education credits. There's a separate evaluation form, and please sign in for that. Fill it out, and you can hand it to me at the end of the session if you would like 3.2 credit hours for continuing nursing education. We offer 0.3 hours of CEUs for social work. Again, sign in and fill out the evaluation form. This is the same evaluation form as the CME. It's together in one group. The CNE, nursing education, is a separate evaluation. And we offer CE credits for physical therapists and occupational therapists. For that, you need to fill out a general evaluation form that's located on the table. And if you have any questions about getting the CE credits or what evaluation form to fill out, just let me know, and I'll answer your questions if I can. And that's our ETGC website that has a lot of good information about other programs that we've done in the past, as well as what we plan to do in the future. I'd like to introduce our speaker and moderator. There are other participants that are going to be working with Dr. Grumbles that she's going to introduce later on. But Dr. Grumbles I've known for several years doing educational programs, and she was born in Abilene, and it's West Texas, and she's proud of it. She received her medical degree from UTMB in '97 and a residency program with UTMB internal medicine between '97 and 2000. Dr. Grumbles received UTMB's award for primary care resident of the year in 2000, and she spent 1 year in private practice as a general internist. But her practice concentrated on the frail, elderly, and terminally ill. She was recruited to UTMB Department of Internal Medicine in fall 2001 and joined the hospice care team as a medical director in fall 2003. She was named Director of Palliative Care Services in 2006. Dr. Grumbles is board certified in internal medicine as well as hospice and palliative medicine. She provides palliative medicine education across interprofessional educational programs here at UTMB. And she's a dynamic speaker, a lot of energy, and a lot of great information she'll provide. And I'd like to just introduce to you Dr. Grumbles.
I'd like to start by apologizing for having to put this seminar off by about a week and a day, but this time last week on a Wednesday at 4:59, I was becoming a grandmother for the first time. And I think most of y'all in the room will agree with me. Sometimes we have to put priorities in place, and becoming a grandmother was a priority over the GEC. And UTMB probably didn't think it was, but I did. So I'm very sorry for the inconvenience that I caused any of y'all. Well, what we're going to do today is we're going to talk about breaking bad news, but it's going to be in a light that I think is going to be a little different from what you usually think of it. Okay? We're going to actually have some role plays, and the role plays are with interprofessionals working with standardized patients. So let's talk a little bit about the learning objectives. What is it that I want you to learn today? This is about health literacy, but in health literacy, we have to be able to communicate clearly and very openly with people. So our primary emphasis is going to be on communication skills, knowing that that's going to help us with our health literacy. After attending this activity today, we will say that we're going to be able to describe the task in a Speak the Truth mnemonic. This was a mnemonic that was created in 2005 by a group of educators who felt concerned that our medical students and our house staff were struggling with delivering bad news. So we developed a teaching mnemonic to help these novice physician learners start trying to deliver bad news with a little more ease, a little more empathy, and with patients feeling like it was being delivered in a little better way. What we found when this was presented nationally, to my great surprise, I presented it at the American Academy of Hospice and Palliative Medicine, and I had all sorts of nurses, social workers, bereavement counselors coming and saying, this is wonderful, we would like to use this with our learners. And of course, the DVD and mnemonic that we created was created for medical students and with that nuance for the medical students. So what we've done now is we've taken that mnemonic and we've started looking at ways that we can apply it to other professions. And that's what we're going to show you today. So you're going to learn the tasks that we put in this mnemonic. Secondly, we're going to understand how to apply the mnemonic, Speak the Truth mnemonic, to some common geriatric encounters that we all are aware of and interact with routinely. And lastly, we're going to actually observe the application of the mnemonic in 3 specific geriatric encounters. Now, since this is going to try to be an interactive session and we're dealing with 5 educational sites, one of the things we're going to have to do is figure out when we're going to mute our systems on our end and when we're going to unmute. So to try to help with that, what I've done is I've developed a little icon here that when you see this icon in the right upper corner of the screen, that means make sure you've got your system on mute. Because I'm going to be providing some lecture didactic or some instructional information, or we'll be watching one of the role plays, and we need to have your end muted. Whenever the little icon goes away, that means we're going to be having some small group interaction, and we're going to be asking your group to actually give us a little feedback about what things you talked about when we were having the small group interactions. So this will be a little challenging because it's a new format in doing interactive education, but we're going to give it a try today. So let me just start with a very, very quick introduction of bad news, and then I'm going to have y'all talk as in small groups and talk about what y'all think bad news is. When I went into hospice and palliative medicine, primarily everyone kept telling me bad news was telling someone they had cancer and they were terminal and were going to die. And the more and more I worked with communication skills with the medical students and the residents, the more I realized things that were not perceived by physicians as bad news are frequently perceived by the lay people, by our patients and our families as bad news. I'll give you an example, one example, and then I'm going to have you talk in your small groups about other examples that you can come up with. I was asked several years ago to teach a section of some telemedicine. And they said, we're not going to tell you what you're going to do, Dr. Grumbles, but it's going to have to do with delivering bad news across telemedicine. Well, that's very difficult because you're sitting on one end of a TV screen and the patient is sitting on the other end of the TV screen, kind of like we're doing here at our GEC seminar, and I'm supposed to be presenting bad news to them. And I thought, oh gracious, if I tell them they're going to die and they just collapse on the floor and say they're going to commit suicide, what am I going to do? You know, I'm miles away from this patient. And I knew it was a standardized patient, but I was totally not aware of what. They kept me in the dark. They didn't want me to know what the diagnosis was or what was going on. And when we got ready to do the patient, and I actually started in the scenario and I started going through the medical records, I realized I was going to be telling a young teenage woman that she was going on hemodialysis. And in my mind, from that moment on, I learned what bad news was. I had been misinformed through my medical education that bad news was when you were going to die. And I realized bad news is seen from the eye of the beholder in what it has an influence on their life, their lifestyle, what they perceive with their goals and their wishes for their future endeavors in life. So knowing that something like initiating hemodialysis is bad news, what I would like to do next is to let the individual groups spend 5 minutes talking about what are other examples of bad news, other than actually having a patient that you're going to tell that you have a terminal diagnosis. And at the end of the 5 minutes, I want us to come back together, we'll unmute, and we'll actually share from our different sites what we talked about. And each site will be giving us an example or two of what they thought was an example of bad news other than a terminal diagnosis. So let's go ahead and start with that with the groups, and I will bring everybody back together in about 5 minutes, okay? We're muted? Okay. Okay. What about my fellows with Dr. Vogelpool? And then, y'all going to be a group? Yeah. You going to be a group?
All right.
Okay. We're going to unmute in just a second and do some small group talking, but I'd like to turn things over to Tony Denuzo for just a second, and he's going to discuss a little bit about the groups.
I just want to get some input. Terry, over in Lamar, told me last week that Lamar, I think they're on summer break there. This is why it's not a lot of people in the neighborhood, so we really get a lot of students. So Terry, just let me know if you want to talk about, if you had a discussion with yourself about, bad news. I mean, which could happen, and we hear your comments. It's not, just feel free to participate in any way that you like. We want to know that you're there and hang in there. All right?
Okay, yes, I had a discussion with myself, and the discussion that I had was about a church member. I am the congregational nurse for my church, and he newly diagnosed diabetic, and he was given the education by the hospital, and most importantly about foot care. He was told that he had to stop wearing the type of shoes that he was wearing, and that he had to buy a different type of shoes to protect his feet. However, he didn't listen to them, and within less than a year, he had problems with both feet. However, probably 6 months after that, he went to the doctor because he had no circulation in his great toe. And at that time, they told him that the great toe would have to be amputated. So.
That's a very good example of bad news, because amputation of even a small digit with walking makes a huge difference, not just the personal loss of a body part, but actually the functionality of the patient. So yes, losing a body part is a very, very good example of bad news. Thank you for that, Terry. What about Baylor? Do y'all have any example y'all want to share?
Okay. Can you hear us?
Yes, ma'am.
Thank you. We had several examples of an elderly person needing to move from independent living to assisted living, be it because their home was condemned and it happened quickly that they need to make that change, or because of their health situation. And that can be quite traumatic and is definitely a grieving situation of loss of their lifetime home, as well as moving into a non-independent situation.
We at UTMB can definitely agree with you that that is a bad news situation, as we've seen that so many times over the last few months with our elders here after the hurricane. So we definitely agree with that one. Thank you very much. What about Pecan Valley in Victoria?
We talked about a number of things, but one of them we talked about was a relatively young person in the nursing home with terminal cancer having to be told they really cannot go back home again, that there's not adequate care for them there.
Yeah, that's a double whammy with bad news, because you have a terminal disease and then you're also being placed in an environment that you feel like you're not fitting in. So that's an excellent example of bad news from two different stimuli coming in at the same time. Good example. What about Stephen F. Austin, what example did y'all come up with?
As you were telling me about. Go ahead.
Okay, well, we were basically with MR individuals who are wanting placement in different areas, particularly the state school, and oftentimes we have to let the families know that at that particular time that the state school does not have the placement.
Okay, that's another good example of bad news. This is bad news. It sounds like primarily directed for the family, not so much for the patient, but actually for the family, which we frequently do that with our geriatric population as well as our younger pediatric population. Those are all very, very good examples of breaking bad news. What I want to do now a little bit is just talk a little bit about why. Oh, I didn't think about. I'm so sorry. Oh, good gracious! I forgot we've got small groups in here. I was so fixated on the screen. Why don't we share in here also? Let's see. We had a group in that corner. Did y'all come up with something different for our bad news?
Well, I think I just want to be going through just not knowing that we were going to be working around that.
Mm-hmm.
We also talked about, people who are having to experience something that after their diagnosis or whatever, they're no longer going to be able to return to the prior level of functional situation that's pretty stressful.
So a loss of functionality, whether it has to do with independence or not, just the loss of functionality. Okay. What about this group up in the front of the classroom here?
One that we talked about was when people are delayed in their release from the hospital and they're begging and getting out on a certain day, and it's bad news if they still have to stay in the hospital. Especially for the elderly who are looking forward to getting out of the hospital, like is everybody. We also discussed the disclosure of the person's first chronic disease state, where they go from a well person to a sick person for the rest of their lives. And the loss of the ability to do their gainful employment.
Okay. That's loss of ability to work is a loss of a functionality, but it's a very special part of our functionality, and it's a big bad news when we lose our ability to do what we wish our mission or our job profession is. That's a very good one. What about the last group in the back? What did y'all come up with? Anything different?
One example was being told that you're not going to be driving anymore. And what we kind of focused initially on was the person who has bad news that affects them directly, and realize that it also, bad news is to, like, the caregiver, and moving from there, it's really goes beyond that to the entire family. So there's like various stages of bad news being delivered, not only to the patient, but to the caregiver, but to the extended family as well. Nursing home was being told you're going to be which has already been said.
Exactly. And one of the important things is communication. Is we have to remember with our elder population, communication many times must be at multiple levels and not just with the patient, because many times we take care of people with some degree of non-decisionality or some degree of inability, impairment in their cognition or their decision making. So it's always important to remember that our communication goes further out than just the patient. And I can tell you that first one y'all mentioned, the delivering the bad news that you no longer can drive, that's my most difficult one to have to deal with my elder population. That seems to be the most painful thing that I tell. They'll take that they have cancer and they're dying in 6 months better than I'm taking the driver's license away from them because they're a threat on the road. So that's definitely bad news. Very good example. Okay, now what I'm going to do is I want to talk a little bit about why bad news is bad news to different groups of people. Okay? each one of us, if we said list the top 10 things that you would consider bad news, we would probably list a few of them consistently among us. But there would be a varying number of things that we would mention. It would not be uniformly across each group, across each individual. And if I asked you to take that list of 10 and prioritize what would be the most problematic bad news, once again, we would see vast differences from person to person. A good bit of that reason why each client is different in what they perceive bad news or what they define bad news in is because we all have different beliefs, different values, we come from different cultures, and we all have different past experiences. With beliefs, lots of times our spirituality, our religiosity plays a big part. What we believe is in our lives or in our future colors how we interpret the information that's being given to us. Values. Each one of us have different values, different priorities that we put on things in our life. So depending on the value that we ascribe to certain activities in our lives or certain knowns in our lives that are going to be changed or altered, is going to change how we view whether something is bad news or not. Our culture, we're going to talk about this next month a little bit with our last session with the East Texas GEC seminar where we talk about the cultural diversity. But truly, we come from different ethnicities, different religions, different types of environments, different communities. There's differences among us that causes our culture to be varied and causes us to look at what we define bad news very differently from one person to the other. And past experiences, I think this is very, very important for the healthcare provider to understand that past experiences colors how they view bad news. We definitely look at bad news differently than what our patients and our families do. And why? It's because we're immersed in bad news all the time. And so we define bad news as being the bad news that we are immersed and involved with all the time. We deal with death. We deal with infirmity. We don't always view some of the things in life that are not associated with death and infirmity as bad news as healthcare providers. So our past experiences have actually changed us. And there are going to be people in the community that has past experiences also that change how they view bad news. An example is, I'm a hospice medical director, and many times when I visit with a family that has been, their loved one has been admitted into hospice, if that family has had a positive experience with hospice but with another family member, or if a close friend or neighbor has had a positive experience with hospice, many times they see a terminal diagnosis not as bad news, but as a way to have a comfortable, good death and escape an inevitable. Other people, when I come in their houses and we're talking about hospice or we're admitting into hospice, they see hospice as a death warrant that they wish they could stave off as long as they possibly could. Once again, it's all past experiences in these patients, in these families, in these clients' lives that's coloring how they define what bad news really is. Now we're going to switch gears a little bit. Now that we've talked about kind of what bad news is and why everyone has different bad news, I want to talk a little bit about the Speak the Truth mnemonic. Once again, in 2004, 2005, a group of medical educators got together and said, our students are horrible at delivering bad news. We videotape our medical students in their 4th year of medical school before they're getting ready to go out and practice in their internships and residencies, and we give them a delivery of bad news case. And it's videotaped, and it's critiqued by a School of Medicine faculty. Well, the School of Medicine faculty were just absolutely shocked when they saw how poorly our students did. And the standardized patients were very vocal about how uncomfortable they felt with the bad news delivery that the students were giving. So in response to this assessment need, we developed this mnemonic. It's called Speak the Truth. Now, the title Speak the Truth kind of takes on some UTMB culture. Because at UTMB, with a lot of inexperienced communicators, as our house staff is, lots of times the assignment of who's going to be the person to deliver the bad news gets what we call turfed around, goes from one team to another team. And when it finally gets assigned to a team that's going to have to tell the patient and family bad news, it may go from the faculty telling the upper level resident to do it, and the upper level resident turfing it to the lower level resident. And I've seen it been turfed as far down as the medical student. So Speak the Truth came up from, we wanted to come up with a mnemonic that would hit home to our culture and tell these young doctors in training, you need to feel comfortable telling the patient the truth. Don't turf it to someone else and try to sugarcoat it or hide it and let somebody else give the bad news. It's your responsibility to give the bad news. So that's where the actual mnemonic came up with. Once we came up with the mnemonic, then we went together to try to figure out how we could use the letters in the mnemonic to help us carry out a delivery system. The other thing we talked about with the mnemonic is that novice learners, whether they be medical students or whether they be social work students or whether they be bereavement counselors, regardless of what training they're actually in profession they're going into, the novice learner needs to have a roadmap to deliver bad news. Emotional experience. It is an unpredictable experience. And to go in without a roadmap as a novice, you're just waiting for disaster to happen, an uncomfortable situation to occur both with you and with your patient and family. So what we did is we developed a roadmap so that when you used the mnemonic, you went from the first letter as the first task you would do to the second letter in the mnemonic as the following task, and so on and so forth. So it's really a roadmap to get you through your first few encounters on delivering bad news. So the S in Speak the Truth stands for setting the stage. We all know it's important how we interact with families and patients, and part of that is how we set our environment up when we're talking with them. We want to make sure we're in a private environment. We want to make sure it's a quiet environment. We want to make sure we've got all the right people there for the conversation. All the players within that patient's family and loved ones that need to be part of that delivering bad news, we need to already have pre-screened and know who those players are so that we can have them present when we're delivering the bad news. Another thing is the physical environment. We always want to make sure that there is no barrier between you and the patient and the family, so that if you need to provide empathy and a therapeutic touch, you can comfortably do it. So we try to stay away from delivering bad news across a big, large executive table. We would rather do it, chair to chair. But at the same time, we have to respect that we in our culture, Western culture, have some restrictions on what appropriate distance is. So we don't want to be too close, but we don't want to be too far away. So what I teach my learners is you want to sit in a position away from your patient that you'll be delivering the bad news, or the client that you'll be delivering bad news to, and you want to be able to touch their shoulder or their knee with just a very, very short bend forward where you can comfortably touch them if you need to apply therapeutic touch. And that's kind of a good rule of thumb to know where you want to sit the chairs and kind of how you want to sit. The other thing is try if you can to talk with anyone who can give you information to know who your players are. There's times when I go into a family meeting that I purposely set myself and manipulate where I'm going to sit so that I know I'm by the person sitting next to the person that I need to. If I have 8 people in the room who are family members, but I know I'm going to have one person that's going to be the primary decision maker or have the most difficulty in accepting the bad news, I want to make sure that I recognize who that person is and I position myself appropriately to be able to interact and support that person. So setting the stage is very important. Something that you do well before you walk into the room to deliver bad news. The second letter is P, prepare yourself. I do this primarily with the medical students, and I'm sure social work students would be the same, is you have to make sure that you've got all the information that you need on that client or that patient before you start the visit. You want to know for sure what bad news that you're giving them. You want to know what their options are in making decision making after you give them the bad news. And so you may have to do a little reading and research and preparation before that meeting. You have to be prepared when you walk in. The other thing that I tell novice learners is there's no doubt that this is an emotionally volatile encounter, especially if it's going to be your first time to deliver bad news. And I actually tell my medical students, if it's not emotionally volatile, we made a mistake by letting you into medical school because you don't have the empathy that we wanted in our physicians when we screened to allow entry in medical school. So I tell the learners, prepare yourself emotionally. Get control of your emotions, take a deep breath, and be prepared that you're going into a highly emotionally charged encounter that you're going to need to keep control of your emotions at the same time that you're trying to communicate and empathetically support other people. The E in the mnemonic is evaluate what the patient knows. This is pretty much just asking, what has the doctor told you? You know, what do you think is going on? Try to find where that client or patient is. Are they expecting bad news? Or are they not expecting bad news? And that will help you position how you're going to respond in body language and in tone and in actual verbiage content when you're talking with a patient. The A stands for ask permission to give the news. I'm going to expand a little bit on a story that happened to me where this really hit hard on me why I needed to do this. We teach in hospice and palliative medicine it's important to ask permission to give bad news. And I thought, that seems silly to me. It seems awkward. The patient's in the hospital, they know I'm coming with their biopsy reports. You know, the patient's coming to the clinic and I'm going to tell them they need to go on hemodialysis. I know they may not be happy with that diagnosis. So why do I have to ask them permission to give that bad news? Well, several years ago, I went into a room with a Spanish-speaking lady, and she was from Venezuela. And she had, actually, no, she wasn't from Venezuela. She was from Spain. I'm sorry, she was from Spain. And I went in with a translator because I speak no Spanish. And when we went in and said, you know, Dr. Grumbles is here and she wants to talk about your biopsy results and give you, you know, the results of what all the tests were. And the little lady said in Spanish, she told the interpreter, no, I can't. I haven't passed my crown yet. And the interpreter told me what she said, and I thought, oh my goodness, maybe the team was wrong and this little lady has delirium and doesn't know what's going on. And I asked her, I said, well, does she know where she's at and what's going on? And the interpreter said, just a second, I think I may know what's going on. And they talked back and forth for several minutes in Spanish, and I sat there and kind of twisted with my hands, you know, in my pockets. And she came back and she said, Dr. Grumbles, she knows you're fixing to give her bad news that she's got cancer, but she has to talk to her oldest daughter because she has to pass her matriarch position. And her older daughter has to be present when she hears the bad news and make the decisions on what we're going to do. Can you come back this afternoon at 2 o'clock when she gets here? That moment in time, I understood how important it was to ask permission to give bad news. Because some patients are just not, or clients are not ready to hear it. And others, culturally, their culture is different from mine, and I may not recognize the impact on delivering bad news with their cultural needs. So asking permission to give bad news is very, very important. In fact, I've learned it's one of the most important steps when I'm delivering bad news. The K in the mnemonic next is keep the news simple and concise. I tell learners 1 to 2 sentences. Give the bad news, figure out how you're going to say it simply, clear, and concise in 2 sentences or less. Don't use medical jargon. Use words that a 9th grader could understand. And then after you say those 2 sentences, you do the most important thing that you could possibly do, and that's zip it up, because you move into therapeutic silence. This is the most difficult step in the mnemonic for everyone, because in an emotionally charged situation, you're pressured to talk. So to be quiet for therapeutic silence, you have to pull yourself back, rein yourself in, purposely say, I'm not going to say anything for a few seconds. Now, learners always ask me, how long is appropriate therapeutic silence? Well, if you're in theology and you're a minister or a pastor or a priest, they tell you it's until the patient talks to you again. If you're a psychologist, they tell you the same thing, but they say we're not that patient. We usually will give them 15 to 30 seconds. And if you're a doctor, the rule of thumb I teach for my learners is I want you to be quiet for 10 seconds. It may be the longest 10 seconds you've ever been quiet for, but I want you to be quiet for 10 seconds. And respect that patient, because the only person who can break the silence is the client or the patient. If they only need 2 seconds of therapeutic silence and they immediately interact with you and start talking and make eye contact, the therapeutic silence is broken. You don't have to wait any longer. Go ahead and on with the discussion. But if they're not ready to talk, if they're not making eye contact and they're not saying anything, the rule of thumb is to wait 10 seconds to give them time to reflect inward on that bad news and figure out where do they want to go next with their questions and with their emotional response. The next letter in the mnemonic is T. Talk about the issue. That's where you're going to give all your information. But once again, be careful that we don't overflow a patient with information, because they're only going to remember about 15% of what we tell them. So we want to make sure we give them important, concise information. And we want to make sure that we don't use a lot of medical jargon or a lot of statistics or a lot of percentages. This is not the time for that. This is the time for the basics about what's going on. Your next visit, you can be more fluid with the statistics and all the different things going on. The R that comes next stands for respond with empathy. This is a lesson that my medical students really struggle with. They're very, very good with this during their first year of medical school. We teach them anytime they're in an interview with a patient, at some point in the interview, they say, "How are you feeling right now, Mrs. Smith?" And the patient will then respond, "Oh, I'm fine," or "I'm scared." And whatever they respond, we teach the resident to then validate that feeling. "I can see you're a little scared. I could tell there was something bothering you." Some type of validation statement. Not that you feel what they feel, but a validation statement that you recognize what they feel. So it's very important to respond with empathy, to actually elicit that feeling, or if you're a good communicator and you can read that person's body language, you may not need to elicit and ask. The vast majority of the time, I don't say, "How are you feeling right now?" I say, "You look scared and petrified. Tell me what's going on." Or, "Your tone sounds very angry. What are you feeling right now?" I feel like at this point in time, I have the skill to read the body language and the tone most of the time and be on base the vast majority of the time. But as a novice learner, what we teach is to say, "What are you feeling right now?" and have them elicit and give you that feeling. And then whatever that feeling is, you validate that feeling with a validation statement. And so that's what we're referring to with respond with empathy. It's not just about handing a Kleenex. You know, lots of people think it's just making sure you hand the Kleenex. There's a little more to empathy than handing a Kleenex. The U in the mnemonic stands for unifying a support team. Bad news is always bad news to the person, and they're going to need support in dealing with it. Sometimes people will say they don't want a support team. They don't want to tell their family. They don't want to tell their friends and loved ones. I say, that's okay. I'm your support team until you decide who else you're going to have for your support system. And I have never, ever had a patient who I did not call 2 or 3, 4 hours after the encounter, and I say, hey, how are you doing now? Because I'm their support person, so I have to call and check on them after they get home, that they don't tell me, I went ahead and called my sister, or I went ahead and told my husband. But at that moment of delivery bad news, sometimes they just don't think they have the strength and the skill to pass that news on right then. So whoever delivered the bad news is the support person until that patient designates who they're going to use, who they're going to share the news to, and designate as who their support system is. Next, the T, totally commit yourself. This is very important in the closure of any delivery bad news encounter. You want to assure the patient or the family and the client that you're going to be there for them. You're just not giving bad news and then walking out and never going to see them again. You're going to be there to answer questions if they come up later. You're going to be able to facilitate for them needs that come up in the future. There needs to be some communication. And lastly, the H stands for help outline a plan. As I mentioned, we only remember about 15% of the information that we're given in a highly emotional encounter. So, helping outline a plan takes the most important information that you gave, the 15% that you've got to make sure that they remember and retain, which is usually going to be what the bad news is, what any specific options you're going to offer to them then, and where they're going to go next. Whether it's back to your appointment for a follow-up, whether it's to a specialist for a follow-up, whether it's to the Social Security office to get a Social Security card, you're going to have to give them specific steps. So you want to be very careful to outline a very direct plan when you're doing this. Now, I know it seems like there's a lot of stuff on this Speak the Truth mnemonic, but I think when you see it play on the video in just a second, you'll see that it flows seamlessly and it flows very logically to go from each of these steps together. So what I want to do now is I want to actually play the mnemonic, and I believe everyone at each one of the off-sites has a DVD. And what we're going to do is we're going to look at the 3rd chapter on the menu page. So if you load the DVD in, it'll bring up, it'll kind of talk through a little bit till you get to a menu page. When it gets to the menu page, you'll be allowed to select Chapter 3 or Session 3. That's a short 5-minute video recording of a physician with a standardized patient actually delivering bad news. So let's take about 5-10 minutes and actually watch this DVD for a second.
Miss Miller's here for her follow-up visit.
Is there somebody with her?
She came alone.
Is she already in the room?
She's in the reception area. I wanted to make sure that you were ready for her. Oh, do you have her chart?
Yes, I pulled it last night. It's in my office. Oh, Bonnie, can you make sure I'm not interrupted when I'm with her?
Miss Miller, yes. Dr. Robinson's ready to see you.
Thank you.
Hi, Miss Miller. How are you today?
Fine. Almost didn't make it on time today because the traffic is so bad.
Hey, can y'all
I know
cut
what you
the
mean.
one camera?
Are
We're
you feeling
getting like
okay after the
double
biopsy?
here in Victoria.
Any
Can y'all
soreness at
cut
the site?
Galveston?
No, not really.
Thank you.
Okay. What did the doctors tell you at the time of the biopsy?
Well, if I had any swelling, just to ice it down, but so far, no problems.
I'm glad it wasn't too bad for you. I have your test results. Are you ready to discuss them?
Sure.
Unfortunately, the information I wanted to share with you was not what I was hoping for. The biopsy results show that you have breast cancer. Miss Miller? Miss Miller? I'd like to talk more about your test results. The type of cancer you have is a common type of cancer in women of your age, and the treatment options range from surgery to radiation
We're
and
getting double
possibly
feed
chemotherapy.
here.
But we'll need to do some additional tests, so I won't have any specific information until then. Are there any questions I can answer for you?
What happens next?
Before you came in today, I contacted a colleague of mine to arrange for a visit. He's a breast surgeon, and he can see you as soon as the day after tomorrow. Would that be okay?
Yes, what is he going to do?
He can explain to you more about the type of cancer you have, do some additional testing, and sit down with you and discuss the type of treatment options.
Do you think there's something that they can do?
Yes. That's why I want you to see the breast surgeon as soon as possible. The two of you can sit down together and discuss which treatment is appropriate for you. Miss Miller, how are you feeling right now?
I don't know what I'm going to do.
I realize this must be overwhelming. Is there someone I can call for you?
My husband's at work.
Let's give him a call, have him come by and pick you up. And when he gets here, we can sit down together and talk about any questions that you might have. Do you want to call him, or should I?
I better call him myself.
Mrs. Miller, although you're going to see the breast surgeon in a couple of days, I want you to know that I'm going to be there for you throughout your treatment. I want to set up a follow-up visit with me next week so we can go over the treatment options that he discusses with you. Bonnie will be here in a minute, and she'll set up your follow-up appointment with me and also give you information about your appointment with the breast surgeon. And if you need any help calling your husband, just let her know. And when he gets here, I'll be more than happy to go over any questions that the two of you might have.
Thank you so much.
Oh, here's your files.
Thank you.
Bonnie, I want a follow-up appointment with Miss Miller next week. And can you help her call her husband right now, please?
Everybody else viewed the DVD? Okay to
Yes.
go? Okay, good. Once again, this DVD was developed for medical students and house staff, and it does use the stereotypical delivery of bad news of a cancer diagnosis. But what we're going to do after break, we're going to take a break here in a minute, and what we're going to do after break is we're going to show you how non-medical professionals, our allied health service professionals, our social workers, our nursing service, how they can use the same mnemonic to discuss issues with patients by using this mnemonic for an educational purpose. So we're going to take a break for 15 minutes, and when we come back, we're actually going to use some role-playing with standardized patients to work on this.
HCTZ, 25 milligrams.
But he doesn't have any painkillers for the arm? That's great. You feeling okay? How's your arm? You can't move it.
It doesn't hurt.
Okay, I think we're just about ready to get started again with the second part of this session. Again, we're going to be doing some role playing, and Dr. Ramos is going to explain that. But I need to make one quick announcement and declaration that basically that none of our speakers or participants today have any commercial affiliations to disclose. So it's official.
Okay. What we're going to do is a role play And to start out with the role play, what I want to do is I want to just introduce our standardized patients. We have University of Texas Medical Branch has a fabulous standardized patient program, and these three are some of our standardized patient actors. So why don't you just go ahead and introduce what your real name is, and then I'll tell them who you're actually portraying today.
Robert Garza.
That's who he's portraying.
Oh, you're portraying who's? I was going to let you. Do you want to tell who you are?
No, that's who I am.
Okay, all right then. Sometimes they actually use these portrayals that we videotape in their portfolios, so I always want to give them a chance if they want to say their real names for publicity's sake. Okay, so we'll skip over that. And what we're going to have is we're going to have a patient who is an elderly gentleman, and this is Mr. Martin Bredson. This is Mr. Bredson's daughter, Katie Bredson Garza, and this is going to be Katie's husband, Robert Garza. Now, the next introduction I want to make is Miss Lisa Ballard, who is one of our social workers and works in our care management office here at UTMB. She is an acute care in-house hospital social worker. And Lisa received her master's degree in social work from the University of Houston in May 1999 with a concentration actually in gerontology. And for the past 11 years, she's been employed here at UTMB as a social worker. She currently works as a core member of our interprofessional team up on our acute care for the elderly unit, for our inpatient elderly unit. So Lisa has lots of experience with this situation. Now, just to let you know that we're going to prove that this mnemonic works, at least I hope we prove it, Lisa doesn't know hardly anything about these people. She's coming in blind, just as if she would if she was walking into a patient's room and had nothing but the patient's diagnosis and the demographics of the patient and kind of the family. Okay? But for everybody else, I want to actually read a little bit about the scenario for the setup. Mr. Martin Bredson is a 75-year-old man who presented to the hospital 4 days ago after falling in his home. He tripped over his small dog and fell up on his left side. He sustained a displaced fracture of his left shoulder, and he had emergency surgery to reset the bones into alignment that following day. His other medical problems are he has hypertension, which is well controlled on low-dose hydrochlorothiazide. He has early Alzheimer's dementia. His social situation is that he's a retired businessman. He's a widow. He lives alone. He manages all of his activities of daily living, and he manages his home and his personal finances. He still drives. His local family is his daughter Katie and his son-in-law Robert. There are 3 other children who all live out of town. The challenge today for Lisa is that Mr. Bredson is going to be ready for discharge within 48 hours. He must be discharged to a situation where he will have 24-hour assistance with care. The daughter and son-in-law have accompanied him to this inpatient conference in the hospital. You should explain the discharge planning issues to Mr. Bredson and his family and help him decide what the best option would be for Mr. Bredson at this time. So I'm going to turn it over and let them role play this out a little bit.
Hi, my name is Lisa Ballard, and I'm a care manager here on the unit, and I'm glad the family, you all could come out. So let me introduce, I'm Lisa Ballard, and you are?
I'm Katie Garza.
Katie.
Bob Garza.
I'm glad to see you. Mr. Bredson, I spoke with the team yesterday, and they told me they had talked with you. I'm going to talk with you this morning about their recommendations.
Yeah.
Can you tell me a little bit about what they told you?
Well, they're telling me that I need to have, 24-hour care. I broke my left arm, and I'm right-handed, so I don't see, why I need to go someplace. I want to stay in my house. I've always done everything for myself. It's just one arm.
Mm-hmm.
It's not like I've broken my back or something like that. So, I'm kind of upset about it.
Okay. I can understand that. Well, I must say that is what the doctors told me as well. They felt like you would need 24-hour assistance when you returned home.
It's fine. It's going to the machines to see.
I just don't understand it. See, and I've got 3 dogs at home. I've got people. My daughter Katie comes in and looks after them and all that, but they're not going to just keep doing that forever. And what if somebody breaks into my house? You know, do they steal my dog? They steal all my possessions and everything.
What does she mean by 24 hours?
I've already been gone 4 days.
Okay. So it's okay. Dad will take care of it. What now? He needs help 24 hours a day?
Yes, because he's not able to use his left arm. And so he'll need help with his cooking, he'll need help with the little bathing.
Now, is this going to be something that is going to be a permanent change? Now, the doctor said that it would heal.
According to the doctors, they felt he needed extensive physical therapy, occupational therapy for at least 6 weeks.
Okay.
Okay.
So after the 6 weeks, then
they will have to come back and be evaluated.
Oh, okay.
But for the 6 weeks, he does need help, and we are looking at this as a temporary situation.
Okay. So
I can feed myself. I can open a can.
Dad,
you know.
Dad, it's really more about the fact that they want to make sure that your arm is healing really well, so you can do strength, and they'll do physical therapy with you and everything. So it's not for longer than 6 weeks, right?
Well, that's what he needs the sling in for 6 weeks, and then they have to evaluate. So I can't really put a date specific time.
So it's really about how he heals and.
Yes, it's about how he heals. And what they don't want is they don't want him using a lot of his energy with this arm trying to do everything, and then you could injure it more. So that's why you have the sling on for comfort, to keep everything in place so it can heal. So that's just what they're saying. But
can you define 24 hours, 7 and?
Well, if he's at home, he gets up in the morning, they want someone at the house at all times. It doesn't mean you're going to be holding on to him and everything, but to making sure he's okay, maybe preparing a meal.
Go
ahead.
Does that have to be one person? I mean, we have a number of people who.
Right, that's what I'm getting at.
We have neighbors who look in on them. I stop by
That's why
at least
I'm
once
here,
a
so
day
we can
now.
talk about all the options. I'm not expecting you to make a decision, but I want to talk about what's available to you. And I know this is very hard for you because you're at home by yourself. You say you have your 3 dogs, they're your companions, and you said you have neighbors. So tell me a little bit about what the neighbors can do for you if you were to go home.
Right now, Katie's coming over to feed the dogs, but I got a couple of neighbors that'll walk the dogs.
Okay.
But I just miss them, and I think they miss me. They're not used to being around a bunch of strangers and everything.
But you know what? I think I might have an option for that. So why don't we discuss what's available?
That would be
great. And then you all can sit and talk together about what you want to do. But I'm expecting you not to give a response. Would you at least allow me to give you options?
Yeah.
Okay. So if he were to go home and he needed 24-hour assistance, there are companies that are licensed, bonded, and they do criminal background checks on their employees. So this would give you a safe person in the home. Now, that is not covered under his insurance. That's normally private pay. Okay.
So I imagine that's pretty expensive.
It costs about $17 an hour at a minimum. And they usually like at least 3 to 4 hours a day.
That's where I was getting to with the question. Define what is 24/7.
Okay.
And
does that mean that person has to literally be there 24 hours a day?
Well, a family can supplement.
Oh, I see.
You can supplement. Let's say you have the person there 4 hours a day for maybe while you're at work, because I think you told me.
I work part-time right now, but I will be probably back to full-time.
Couldn't I stay over at your house for a while like that?
Well, Dad, remember the hurricane took out the extra room? We had that flooding, so we have all that construction everywhere, all over the house. So we don't really have space for you right now.
Now let's also talk about, as far as having help in the home, we normally recommend that you go with an agency that's licensed and bonded and insured, okay? But there are some individuals that you might know that we keep a list that you can talk to, but you're still going to be looking at least about $15 a month.
Okay. Well, that's a lot.
For 6 weeks.
I've got some savings,
Minimum
but I'm
of
not
6
wealthy.
weeks. Okay. Well, let's look at another option. Okay. Another option would be going into a skilled nursing facility, and we use the acronym SNF. Do you know what that is, the skilled nursing facility, Mr. Francis?
I don't, actually.
Okay.
I'd really like to know.
Okay. A skilled nursing facility is a place where you have to come by way of being in the hospital, and it's usually for our geriatric patients when they've suffered maybe a hip fracture or just a similar situation like yourself, and they need a little bit more support or help at home until they can get strong enough to be back home.
Oh, okay.
So the plan is a short-term stay to get you back home.
At a nursing home?
Well, it's not permanent. It's not, it's a short term.
A skilled nursing facility, it is located in a nursing home building. That is the truth. But, however, most of these facilities, they have one hallway designated for people who were at home, independent, and they need a little step down before a little bit more physical therapy, occupational therapy, or nursing before they can go home. The key is that we want you to be safe.
And what kind of, does the insurance cover that, or?
Well, let's talk about that. Now, I actually brought something so I can show you.
Okay.
But here again, this is something I recommend to all my patients. This is a senior guide. You can pick it up from Walgreens.
Okay.
In the department of the drugstore, and you just ask for the book. It's free. Okay?
Okay.
And let's look at what Medicare does. Okay.
We have to keep that in mind because
It's a good book. It has lots of resources.
Yeah.
Okay.
well,
let's
our
look
resources
at
are
it.
limited.
Yeah,
Because I like for my
definitely.
patients to see what I'm talking about, okay? So we're looking at skilled nursing facility, okay? Medicare pays the first 20 days 100%. That means you pay nothing.
Okay.
It does not affect your pension. It doesn't affect any of your other benefits or what you have at home,
So
okay?
that's almost half of it right there.
Yeah. Now, on day 21 through 100, Medicare will continue to pay all but $135 a day that he would be out of pocket. However, I looked at his insurance and he has Blue Cross, Blue Shield.
He has the supplemental.
Normally, they will pick up that $135, but we have to have it run. That facility, if you choose a facility, would run all his information and would determine that. But most of the time it does. So he would have up to the 100th day with that.
So that would
But
cover
he might
it
not
if-
need all of that. That's what
Yeah,
he-
that would cover it if he, oh, that's interesting.
And that would be,
And then what happens if it turns out that he has to stay longer?
well,
that.
we're looking at, well, when he comes in for his follow-up appointment in 6 weeks, they will evaluate that. He has up until 100 days. Most likely he won't use, but
Okay.
if he goes over the 100
Then he
days-
has to go somewhere else after that, is that
Well,
what
he
you're
would
saying?
normally be private pay for the $135, or you could actually, sometimes you can go home. He might be strong enough to go home. Maybe you're doing better just a little, you
Yeah,
can go home
yeah.
with home health. That's what a lot of people would
Okay.
do. And we
Okay.
could- and that's 100% paid
I
for.
think that's if insurance pays for it, it seems like.
But you know, this, here again, these are recommendations.
Mm-hmm.
Okay?
Is there a way that I can just stay in my own house?
Dad, we have to make sure that your shoulder gets better before.
What's
it's-
going to make it any better if I'm in a facility
Because they're
or
going
at
to do
home?
exercises with you, and they're going to check on it, and they're going to make sure that you're using it properly. They're going to make sure everything is taken care of, so you don't have to
Tell me, if you were
use
to go
it for anything.
If you were to go home tomorrow, let's say you're discharged tomorrow, tell me like a daily routine. What would you be able to do? Because you have to, you normally use two hands. It's kind of, you're thinking about it now, but when you get home, you're going to find out you're going to need your other hand. Can you tell
I think
me?
I can bathe myself,
Okay.
pretty well, and I can probably find some foods that, I can eat. Be there to feed the dogs, and I can walk them, my right hand,
We'll take care of the dogs.
Yeah, don't worry about the dogs.
We like the dogs, so we'll take care of the dogs. And,
This seems to be this is very difficult because remember, he was independent. He's
Yeah,
at home.
yeah, absolutely.
He was driving.
Honey, it's just temporary. It's all right. Dad, we just got to get your shoulder better, Dad. Let me take care of you. Don't worry.
I'll never come home
Oh,
again.
yes, you will.
Tell me what you know about nursing facilities from your experience.
It's where people go to die.
Oh, Dad. That's not what's going on here. You just hurt your shoulder and you need a little.
No, it's just my arm and my shoulder. And
That's a common myth around Jerry, that you go to die, but that's not necessarily true for you. Remember, you were independent. and you were doing a lot for yourself. And what we want to do is just make sure you're safe. It doesn't mean you're going to die. You're healthy.
You're gonna put him in like an independent wing area.
Actually, he's going to be on a wing. His rooms will be semi-private. Now, if he wants a private room, you do have to pay a little bit more. But remember, on this particular hallway, I went to visit, and it's really upscale, it's upbeat. So you're not, a lot of people think when you go to a nursing home, you're going to see people falling over in wheelchairs. That's not what you're going to see in your wing, pretty much. There are people just like yourself that they are motivated to go home. And that's the key to going into these places, that you're going to be motivated to do whatever the therapy they're asking you to do. And the quicker, usually people heal fast because you're actually motivated and you're participating. So motivation is a big key. But I do understand where you're coming from. Now, as an option to you, I know you have 3 dogs, right? And there's a skilled nursing facility that actually has the Edenized concept where man and animal live together. So if your dog is up to date on his license, you can bring one dog that can be a part of your therapy with you.
Just one dog?
Well, no, I don't think they will take all 3, but one dog, yeah. But he has to, we have to make sure it's one of your dogs that's more calm and maybe could get along with the other animals. But that is an option. And then that way you have one of your companions with you, which is really hard when you have animals. It's an option.
We're forgiven for tripping you.
But again, I'm not asking.
Ted.
Well,
you wouldn't have to be without your dogs altogether.
If I knew I was going to be back in my house at the end of all this.
It's just over a little over a month. So
we'll take everything, and we'll take care of everything at home. And they'll get you strong enough to come back.
What else can your neighbor do? I know you said you check on him every day.
I'm usually there. I bring him food and things like that. The neighbors generally stop by to check on him.
And one thing,
taking his mails.
Okay, so that was one thing I know you were concerned about, someone breaking into your home. One option would be like, you told me, I think you said his neighbor has a key to the house, where he could go in and put the mail in the house, and at nighttime, if you have a light that's not censored, you could turn on the porch light, things like that, and make sure, to make sure it would deter other people from coming in thinking that you abandoned. And so I think the fact that you trust someone with a key to your house says a lot. So
Roger would be happy to do that.
But remember, I'm not asking
you. You and Robert could stay over there one night a week or something like that?
I might be able to stay over there.
We can do that.
Oh, that would be good.
Yeah, well, we want to be with the dog, so
they need somebody around.
They need somebody around.
Okay. So I'm going to let you all talk a little bit more about it, because I don't want you to make a decision because you're emotional right now, and just feel good about the decision you make. But I want to give you this also because the facilities in the area, you need to have a list so you can go and look.
Yeah, we like that, yeah.
And you can, while he's here, you can give him feedback about what you think. And I actually printed up this is from the Department of Aging and Disability. And you can look at this, you can look at their scores, how well they've done in the nursing home, their performance. So, and I've put on, I've listed them all here.
And these are all ones that have the temporary, the rehabilitation.
Yeah, they all. This is what you're going to look for. You're going to look for, as long as it has the acronym SNF.
Okay.
That's a skilled nursing facility under Medicare.
Okay, and that's what that is.
That's what you're looking
motivated to get out of there.
To get.
See, that's we're going to choose someplace especially so that you can get out.
And so now I'm gonna leave you my card because I want you to call me because I'm gonna be here for the entire process with you. I will be your discharge planner.
Thank you.
Okay. So let me give you, and I want to give your family a card. And then my name is written on the communication board in your room. So anytime you need me, if you have any more questions, because I'm not expecting you all to remember all this because I do this every day. So you can call me at any time. The nurses know me. Just say you want to speak to Lisa, and I'll be available. Okay?
Okay. Thank you so much. Feel a little better?
Yeah.
That's good. We're just going to get your shoulder taken care of.
Good.
Very good. Very, very nice role play. Let's give them a hand. Very nice. I want to take just a second now to kind of debrief the group. First, I want to start with Lisa. Lisa, how did you feel the session went?
Well, I really didn't know because I didn't know what they were going to come at me because I usually read the chart thoroughly, and I usually meet families before, at least the patient before I meet them in a conference like this, so I have a little bit more information. But I was nervous, and he did such a good job when he cried. I almost cried. So it was good. Although I knew people were watching, I had to really kind of forget about them, and I was a little nervous, but I think it went well. I mean, just you have to kind of work it as you go. You have to, okay, this is where he is right now. This is where he is. I got to redirect this way, and then trying to meet her needs at the same time. They're asking questions, and he's here and there. So I was trying to, I got to accommodate everybody in a different way.
You did a very, very good job. I was very impressed with how you were recognizing and validating everyone's needs and doing that. How did y'all feel with the encounter? Anything that you thought went well or that you thought was a little problematic that you would like maybe addressed in a different way?
Not really.
No, I thought she did a really amazing job. She's so clear.
I didn't try to throw her off.
No, thank you.
That's my job. So,
That's what we do.
So I tried, but she recovered real quick.
And that was my job to throw up obstacles, but you were very good about it. Katie was very good, Robert was very good, everybody. I think we worked out a solution that if it was the real me, I would be comfortable with that.
Good, and that's when we role play. That's what we try to do. We try to say, if this was really us doing our job, or if this was us as a patient or family, would we feel comfortable with what went on, with a decision that we would really make? So that's why it's important to kind of ask the role players how they felt about that. I think Lisa did a marvelous job in addressing the issues. The issue is looking with empathy when we're delivering bad news. And actually, she recognized what were really the suffering. It wasn't pain from a shoulder that he was worried about. It was the fear of loss of independence, the fear of maybe a nursing home was a death warrant, and it was a fear of losing his companions of his dogs. And I think you recognized all of those and dealt with those very, very well. And that's part of the big important thing when we deliver bad news, is looking for the things that family and patients and clients see as bad news that, once again, we may not, as healthcare providers, really think is bad news. So I thought y'all did a wonderful, wonderful job. Now I want to.
Do you think there'll be any feedback?
I'm just listening.
Okay.
The next thing I want to do is I want to open it up to the groups to have them actually see if they've got any questions, any feedback, any comments that might they'd like to share with the groups. Anybody with anything?
All right, you can say it. We got some. Yeah. Oh, sorry. This is from SFA.
Okay.
Yeah, go ahead. There. Yeah, I'm ready for Carol May. I used to work as a social director in nursing home, nursing facility, and I experienced the same problem. A lot of times we have residents that discharge from the hospital to the nursing home, and a lot of times they're only, we tell them they're going to be there like 3 weeks as per doctor's order. And during that period of time, things changes, and a lot of times the patient becomes upset and distrust in the worker because they looking to go home, they're going to treatment, but just because of other illness developed during that period of time, they're there longer than 3 weeks, and sometimes they're there during the duration. And you start having different outbursts and behavioral problems. Is it different things exist during that period of time?
Having to work and deliver that type of news, and why they have to stay longer is a challenge, and you can see the benefit of being able to deliver and work on how you communicate that information.
I think that's why she kept saying 6 weeks, and I kept saying I can't say.
Yeah, I think Ms. Bellard really picked up on that, because I think the family was really wanting that definite time schedule, wanted to know what that timeline was. And I think Lisa did a very good job by saying we're expecting 6 weeks, but we need to reevaluate at 6 weeks. And I know it's very difficult. We may do this in the acute care setting, and when y'all see them after they've been there for 3 or 6 weeks, the remembering, because remember, we only remember 15% of what we got told during that bad news encounter. they may not remember that they were told it hinged upon reevaluation and progress in safety. So once again, I think it's very important for continuity of care for the nursing home and the skilled nursing facility to keep re-emphasizing these things. Not just that you're there for 3 weeks, but that we're constantly assessing and making decisions on when it's safe for you to go home. That's a very, very good point to bring up. I think Dr. Snoterman, you had something you wanted to mention?
Yes, also I think she did a great job in committing at the end of the encounter. This is my card, this is my name, you can contact me anytime for whatever question you have. That part that she really emphasized, and I think it was really important. I think as a patient, it's important for somebody to get in touch with questions required information.
I agree. I think she did make that bond, and I think did y'all feel comfortable that y'all could call her? If y'all had questions or something come up, you would have felt comfortable getting hold of her? Good.
Absolutely. Because if you're handed off to somebody else, they don't know the promises that have been made or anything. So that was great to know that you still have the same person to talk to.
That continuity is really important. Sometimes that's hard to keep going, especially in a hospital or transferring from one disposition area to another. Any other questions or statements?
I had 2 comments. When it was really when you asked, like, well, what do you do during a day? You know, describe a day, and he mentioned, well, I could walk the dogs, you know, with one arm, and I'm thinking, I have 2 dogs, and I have a hard time doing that with 2 arms. You know, with leashes going. I mean, to put a leash on a dog with one arm is not easy. But the thing is, do you encounter that? I mean, do you point that out as it gets argumentative, you know, which I guess you want to avoid, but you know that there's probably things that he can't do with that one arm. So do you just let that go, or do you bring those up?
Well, what we do is redirect, like I did.
Right.
I kind of redirected.
Exactly.
Now, I did have a patient once who couldn't go up the stairs, and we didn't think he could, and so we wouldn't discharge him to clear him unless he practiced the stairs on our unit. And so he was, no, I can do it. I'm an Army veteran, you know, I can do it. I mean, we went like for hours, but he finally did agree to do it because that was, they weren't going to allow him to go, so. But for his case, I had to redirect it because there's no way I was going to be able to tell him, there's no way you can do that.
Think about all
so
you don't want to go
there. So you just redirect and go to something else. And,
that's really good. The second thing was that when you mentioned about that you bring the dog to the skilled nursing facility, really I thought, oh, that's a good thing. Are you sure you can do that? I mean,
there is one.
Right, I know.
Oh, okay.
But you know, the dogs have to be.
You have to have
shots
and up to date. Yes, different things.
So all that information is given, and you know, because that'd be really devastating. If you go there and you set it up.
That's true.
They won't take them.
And normally after I finish the session like this, I do go back a little bit later, and then we'll go over. Sometimes more specifics come out, and he would ask questions. So and I really help if there's going to be an animal. I usually will. If you get me the shot record, I'll get it faxed, or if you get it over there. So I'm really involved in that totally when we're doing that because I know it's going to be a part of him staying there, and it's going to help with his therapy.
Great.
Okay, very, very good. I want to thank Lisa. She did a marvelous job as a social worker. We're very, very happy to have her as part of our interprofessional team on our inpatient geriatric unit. Okay, now what we're going to do is we're going to move to another scenario. And with this scenario, it's going to be a little different. And what we're going to do is we're going to age Mr. Bretson a little bit. He's going to be 7 years later, and Mr. Bretson is now 82 years old. And he's not going to be present at during this role play, but you need to remember that he's aged by 7 years and he's now 82. He is still living alone in his home, but has progressed with his Alzheimer's dementia. Remember, it was 7 years ago, it was mild. Now we're dealing with moderate Alzheimer's disease. And it's to the point where he is no longer safe for him to be in the home without 24-hour supervision. Several issues have arisen, including episodes of wandering, leaving the stove burning when not cooking, traffic violations, and many misplaced items. He is not able to communicate fluently. The daughter and son-in-law are in the clinic to talk to you today at your request. The challenge, now I'm going to do this role play, so my challenge as a physician is they are both there are both health and safety issues for Mr. Bredson, and I should inform the daughter and her husband that Mr. Bredson is no longer decisional and should recommend 24-hour care or supervision for him. I should explain why this is necessary and respond to their questions and their concerns. So this scenario would be set up either in a physician's office, his office. It could be his office with desk and chairs. It could be in one of the patient care rooms. But this is going to be a visit with the family without the patient present. Okay, so the family has concerns, and I, as his physician monitoring, now have concerns. Hi, how are y'all doing today?
Hi, nice to meet you.
Remember me from the hospital, Dr. Grumbles? Okay, good. Now let me see, it's Katie and Robert, right? Okay, good. I know when I called and asked the nurse to ask y'all to come in, the nurse had asked some questions about whether you had any concerns about your dad, and you'd shared a little bit. Can you share that and kind of tell me what y'all thought was going on and why I was asking y'all maybe to come in? Because the nurse told me she thought y'all pretty well knew kind of what I was going to be asking and talking about today.
Well, my dad has had some problems with not knowing where he is sometimes, wandering. Last week I came over and the stove was on. He has a gas stove, but he wasn't cooking anything. And I asked him about it, and he said, "Oh, I was just making some tea when you interrupted me." But I talked to the neighbor, and she said that she had found it on once. But really starting to get worried about him. He's starting to kind of seem like he's kind of forgetting a lot of things, misplacing time. Yeah, he does.
But
talks a lot about mom as if she's kind of still around. Yeah.
Okay. Is this concerning to y'all?
Well,
it should be.
Okay.
Yeah, I mean, we just want to make sure that he gets everything he needs.
Okay.
You know, we're not quite sure how much care he needs or what kind of options we have.
Okay. Well, this is why I brought y'all in today, because I wanted to take a little time to share with you my concern about his health and safety. And it sounds like y'all felt the same concerns that I had. And I want to spend some time about options with y'all. Now, you'll have a few minutes, we have time that we can kind of talk this over?
Yeah.
Okay, great. Well, in looking at your father now, he has progressed to a point with his Alzheimer's disease that he is no longer decisional. He doesn't have the judgment and the insight to make daily safe decisions. And because of that, we have to recommend that he is in a safe environment, which would mean what we call a 24/7 supervisory state, where someone doesn't have to be with an eyeball watching him all 24 hours, but someone has to be within the home or within a facility where he can be monitored and his safety would be evaluated 24 hours a day.
We went through this 6, 7 years ago?
7 years ago now, yeah. With the shoulder when he tripped over.
Right. Are we talking about the same thing?
No, this is a little different. Back when your father broke his shoulder, he was decisional. I mean, yes, we had some dementia symptoms going on, but other than the shoulder, he was able to feed and clothe and take care of himself and balance his checkbook. And so I wasn't concerned about his safety. I was more concerned about accidental falls that might have occurred because one arm isn't working and he wouldn't be able to do things as he used to. And two, I wanted him to get the best physical therapy and occupational therapy he could get to make sure that we had successful rehabilitation of that shoulder and arm.
It was great.
And he did wonderful. I mean, he responded well to the rehabilitation. Now we're talking about a different problem. We're talking about not that he needs physical therapy or occupational therapy or he needs someone trying to teach him to be safe. He needs, like we do with our children, to just have an overseeing eye to make sure he's safe.
Oh, he's gonna hate that. But I'm worried if he gets in that car again, he's gonna kill himself or someone else. If he forgets where he is, if he forgets that he's driving. Can you tell me about what this costs?
Yes.
How that's going to affect his retirement?
I can give you a little information about that. As his physician, I'm not the best person to give that kind of information, but I can give you some basics, and then I'll set an appointment up with the social worker who can give you more specifics.
Oh, okay, great.
Okay?
Part of our concern is that, like the last time, it put a dent, even though he was covered and he had Medicare and he had insurance. It still put a dent.
A bit dent. Mm-hmm. Yes.
And if this is for good, like it sounds like it is, her options are.
And I can see you're concerned with that. In the majority of families that I deal with this circumstance, this is the thing that really seems to be worrisome, is how can we afford to do the best thing for Dad?
Exactly.
So you're not alone with that. This is a common question that people have and a common concern. Let me start by kind of explaining areas where we can do 24/7 supervision. Okay? There's always families who bring the loved one into their home and arrange their work schedules, their home schedules, other extended family members' schedules around providing a safe environment for the person, where there's someone in the home with them living with you, and there's someone always in the home, kind of like we would when we have our children. We have small children, we make sure that there's an adult in the house. It doesn't mean that the adult's staring at the child every second of the day, but we know that there's that safety net of adult in the house overseeing the children. Some families choose to do that option where they have the elder move into the home and the family provides the oversight.
We just moved into a very small place. So we definitely can't do that.
That's not an option.
That's unfortunately not an option.
Well, let's talk about some other options. Okay. There are facilities that you can pay, such as what we call personal care homes. Personal care homes are licensed by the state of Texas to keep just a small number of elderly people living in a home-like environment. We see them scattered around the county, and there'll be a home that has 4 or 5 bedrooms, and they may have 6, maybe 8 elderly people that live in that home, and the personal care home provider provides 24/7 supervision with sitters that are in the house, people that are cooking, people that are helping with hygiene and things
so he'd
like
be living
that.
in a house
with other elders.
Like a dorm?
Usually it's actually a home. It's very seldom a dorm. Like it's a small, the state of Texas only lets a certain number of elders live in a situation. It's to try to provide a home-like environment when the family can't provide the home-like. This, once again, it's expensive. It runs usually from somewhere around $2,000 to $3,000 a month, depending on the facility. The social worker can give y'all a little more information about that, a little more specifics.
It sounds great, but there's no way he can afford that.
Yeah.
Let me backtrack to the conversation about the last time making a big dent. 3,000 a month is.
It's not going to be a possibility. That's just.
I understand that. I just want to make sure you know what all the options are, okay? And I do understand that finances are going to really play a part in the decision that you make. Yeah. But I want you to know the big picture, okay? The third area that we have, of course, is long-term care, or the conventional nursing home, where people go to live in the nursing home. Not the skilled nursing facility that we were talking about 7 years ago. It's like the rest of the nursing home. When he was in the ward that did the skilled nursing facility, we're talking about the rest of the area of the nursing home where people go to live, usually the rest of their lives, and that is their home, is in the long-term care facility. Now, It is also very expensive. It runs anywhere from usually $3,000 to maybe $4,000 a month. But let me say that I would like for y'all to talk with the social worker, because there are ways around the financial issues sometimes. Sometimes there's ways to spend down certain money that he has that qualifies him for other funding. You need to know about that. Sometimes it would put a financial constraint on y'all starting out, but not a lifelong constraint. So you need to talk with the social workers and the long-term care administrators that really understand how we fund people who need to live in long-term care administration type situations. Okay? So I don't want you to say no to personal care homes or to the nursing home until you've talked with the social worker and gotten more information than what I can provide for y'all.
That was just going to be my question right now. So you are not, right now, you are not the last person talking to us about how to get this done.
Absolutely. I'm going to get y'all more assistance. I'm outside of my realm of expertise. I needed to tell y'all my concern and explain medically why he was a risk to his health and his safety and what we needed to do getting 24/7 supervision. But I'm going to now refer y'all over to the social worker who can really give you the nuts and bolts of what we can do to make this happen and find a way that we can get your dad in a safe
That would be great.
environment.
Yeah. Are there is there assistance for such things? I know that you said, there are some things that they could probably do, but this isn't anything that Social Security or any of that assists with?
The Social Security and the regular Medicare benefit does not assist with it.
Cool.
I'm hoping the social worker can check with his supplemental insurance to see if maybe there's some supplemental insurance benefits that could maybe defer some of the cost. But once again, the social worker will need to analyze all that and then call the companies to try to get y'all some more information regarding that. I want to let y'all know that I'm going to continue to take care of your dad. I've known him for years now. I regardless of whether he lives in the home with y'all, he goes to a personal care home, or he goes into a nursing home, I would like to continue to be his primary care doctor, because this is going to be a struggle for him with this change. It's been a struggle over the last few years with all the little changes that have happened, and this is going to be a struggle for him and a big change. So I'll be there for him and try to help smooth this change out for him and for y'all as much as I'm capable to do.
Thank you.
Okay. So why don't we do this? Let's step out to the front desk, and I'm going to have them call and make you an appointment with the social worker so that y'all have a time to come back in. I'll also give the social worker time so that she can get copies of all of his information that she's going to need. She may need to call you on the phone, maybe to get some preliminary information so that she'll be prepared to give you all your options when she talks with you. And then have you come back and actually sit down with her and try to work out this, what seems to be a financial issue. I hear that y'all agree with me, he needs to be safe and we need to do something, and y'all want to do something. We just have to find a safe alternative that we can manage to afford for him and y'all. Okay?
Okay.
Okay, well, let's go up and see about getting your appointment set up.
Great. Thank you very much.
All right. I can.
A home, old man.
I knew they were going to hit me with that small home thing. This is a very, very common scenario that physicians have to deal with. And the problem with physicians dealing with it is that we do not have the expertise that the social workers do. And so all we can do is provide an umbrella of options. And many times it becomes frustrating to the family that as a physician, I can't answer all those questions. Well, on the flip side of that coin, it also allows physicians to dump on the social worker because it is the physician's responsibility to assess the decisional state and the safety state and to communicate that to the family. So this is a scenario that sometimes the doctors do, sometimes the social workers do, and my recommendation is that it be done as a combination with the two. Yes?
Dr. Grumble, one of the things that we have here is they're very cognizant of what's going on. They've already had a successful event that turned out well, which leads them to be real receptive to what you're telling them. They're very aware. In your next scenarios, are y'all going to cover what happens with people who are recalcitrant, don't want to accept it, don't want to take responsibility? Okay, then in that event, what's the responsibility?
Well, when I have families that are recalcitrant, it's one thing with if the patient, because the patients I've already said is non-decisional. So if it's the patient who's giving the problems, the issue is I as the physician am ready to help the family walk through guardianship and surrogate decision making for the benefit of the patient. If it's the family where the problem is, it's just a continued issue of working with them. Now I don't like to pull the APS card, but I can tell you when I have a family that just refuses over and over to step up to the plate for responsibility of a loved one who's in an unsafe environment, I will tell the family that I am going to contact Adult Protective Services because I am concerned that that patient is not safe and I need to do something urgently to try to start rectifying that problem. In my experience, about half of the recalcitrant people will all of a sudden decide Dad can move in with them, or that all the kids can get together and take turns farming him out or take turns with something. But then there's the smaller group that literally the family refuses to step up to the plate from the ethical issue and from the financial issue, and it's usually due to the financial issues more so than the change in their lifestyles. And then I do call the Adult Protective Services and tell them I have an issue that's not safe anymore. But I can tell you right now, and I tell my young residents and fellows know, I say this over and over, it's not a quick fix. You don't call the Adult Protective Services and 24 hours later your patient is safe and the family's happy and the situation is taken care of. We're usually talking about weeks to months, if not years, before a resolution can be come about with.
Repeated contact with Adult Protective Service every
Yes.
time they come in?
Yes. Keep that case open. Every time something comes into your office or into the hospital, you need to call to see if that case is still open. If it's not open, you need to get it reopened back up. You need to keep the pressure on from the healthcare provider's standpoint. Exactly. Okay. Do we have any questions or comments from any of our off-campus facilities? No? Okay. Well, I tell you what then, let's move on to the next scenario. Deborah, you want to come on up here and take a seat? I have another social worker role-playing with us today, and she's in a little different position as a social worker. Deborah Perryman is has a master's degree in social work from the University of Texas in Arlington back in 1996. And for about 30 years prior to that, she was a long-term care administrator at nursing homes, so has a lot of experience with long-term care administration. And over the last 10 years that I've known, 14 years now that I've known Deborah Perryman, she has worked in the hospice, community hospice arena, and she is now the executive director of a community hospice called Hospice Care Team here in Galveston County. So, with that being said, let me read the last scenario that we're going to role play. Mr. Bredson is now 84 years old. and he's admitted to the hospital because of a cough, fever, and shortness of breath. The workup reveals that he has a post-obstructive pneumonia due to an aggressive non-small cell cancer of the lungs. He has metastasis to his adrenal glands. His prognosis is poor, and his life expectancy has been communicated to the family as being less than 6 months. Mr. Bredson, Alzheimer's disease is now severe enough that he does not understand his disease, nor does he understand his prognosis. So the challenge is going to be that Deborah should recommend hospice care to the family and answer their questions and address their concerns. And I would just like to say that Deborah can tell you there's many times the physician does not do their job of delivering the bad news of a terminal diagnosis, but this family knows that it is a terminal diagnosis and that we're only expecting about 3 months prognostication of life survival. And they've already talked with the physician about that. So all the information is going to be related to the hospice and the services. It's not the delivery of bad news. It's the delivery of bad news in how things are going to change in life and in the future now with this terminal diagnosis. Okay?
Good afternoon. I'm Deborah Perryman, and I'm with Hospice Care Team. Dr. Grumbles has asked me that I come by and visit with you. I like to begin my interviews if you could just share with me a little bit about your father and what the physicians have told you.
Well, he just came in with a cough, and they said that he has lung cancer now, and they said he has 6 months at the most. He's been not really very aware of what's been going on around him for...
It's not with us right now.
It's been at least 6 months or so.
He does not live with you, I understand.
No, he does not.
No.
Are there plans with the terminal diagnosis that you might be taking him home?
It's just really not a possibility. We live in a very small place now.
It's part of the reason why we're here.
Yeah. We just don't have the means to take care of him in our house. And we want to make sure that he's safe. So, I guess we're just kind of wondering what our options are, how much they're going to cost.
What can you tell us?
What I'd like to do is share a little bit with you about what hospice does provide. Hospice services make sure that we understand what a patient's and family's wishes are in regards to quality of life. What we would like to give your father is the things that are important to him as an individual, what is important to you as a family, and how would we make that work. Dr. Grumbles would remain his physician under hospice care. She is one of our medical directors. She would oversee his care. He will have a nurse assigned to him who will visit on a weekly basis. We have aides that come out and can provide some personal care for him, and that's just to give him some extra TLC. We also have a chaplain for spiritual support. I'm one of the social workers, and we provide the emotional supportive care, make sure that resources are accessed as needed. We also have volunteers because we recognize that families' lives are very busy, and unfortunately your lives will continue to go on, and to give him some extra support to perhaps come out and sit and read to him, listen to some music, find out a little bit from you what his likes and dislikes are, and to see if that might be an option.
Can I ask you how this is different from a nursing facility?
What's the difference?
It's different. It is a very good question. It's different from the nursing facility in that the nursing facility will continue to provide him room and board, and that would continue through whatever financial arrangements you've already made. I noticed on his chart he had been eligible for Medicaid, so that's taking care of the room and board. The hospice benefit is under his Medicare Part A, and that will cover all of our services, which are the professional services he would receive, as well as covering any medical equipment such as oxygen, an electric bed. wheelchair, shower chair, whatever's needed for him.
So there's no place?
There's no place.
Okay, so we would have to find him a place.
No, ma'am, he may stay at the facility
Oh,
he's
okay.
at because
Okay.
we do have a contract
Okay,
signed
I
with
see.
him.
Oh, so it's just a difference of
Having extra people?
organizational name.
Well, then have
It's-
more people.
Oh, okay.
More people. The
Right.
nursing, generally in a nursing facility, in a long-term care, you're looking at people with chronic illnesses that anticipate care on a longer basis. With hospice care, a prognosis of 6 months or less is one of the criterias, and what we focus on is what is in those 6 months. What can we do to provide end-of-life care for your father? If it's managing his symptoms so that he's not short of breath, certainly we don't want him hurting, having pain. If it's important for him to have church service or to have someone come out and read scripture and pray, then our chaplain can certainly provide that care for him. If it's important for you as a family to talk about completing his end-of-life business, has he done a do not resuscitate? Have you talked to Dr. Grumbles about if his heart stops beating, if he's not breathing?
We're taking care of all of that
You
now.
have, okay.
Yeah,
That's excellent.
It has been our
Excellent.
job for a while.
Good.
It's not,
Funeral arrangements,
not yet.
those are
We're
tough.
not there yet.
I know. And those are things that we can, as a hospice team, can help prepare and guide you for when the timing may be. We don't have a crystal ball to know what date and time his life will come to an end, but we can certainly assess him with the team and can see and again inform and educate you what we're seeing. We have literature, and I brought just a few things today to share with you as you begin preparing what to expect. There are going to be days that he's going to be more like himself, that he may enjoy sitting outside in the sunshine because that's something he always enjoyed doing. He may enjoy, you may walk in the next day and he's just totally not responding to you.
But we're there already.
You're there already.
Yeah, but he's definitely
That's
been.
where we're at.
Does he recognize you at all?
Some days not.
He may.
Yeah, mostly not.
Has he been talking to other family members that have passed away?
No, I don't think he's done that.
Just talks a lot about the past.
Yeah,
And
just
your mother.
nostalgic.
And that's good because he may be engaging in a life review, and that's some of the literature I brought that we talk about the importance of listening to patients. At 84 years old, he has 84 years he wants to review and kind of weigh and see how that has been for him and where he's at, if there's any unfinished business, even inside his own heart that he may not can express to you, that he may be reviewing and looking at. We have staff that is, our staff has extra training to deal with end-of-life issues so that they can again be your guide and let you know what's going on.
So what you're saying is that hospice care is, it's gonna be, we can have it at the same facility. It's just a different team.
It'll be a different team, and we will work with the facility to coordinate our plan of care. And again, Dr. Grumble sees him at the facility as well as our medical director. So our plan of care will be written according to what the patient's and family's wishes are, and then from the medical direction on how to carry those out.
So you're basically saying that the long-term facility that he's in now cannot continue to care for him sufficiently?
What we want to perhaps look at is that they will continue to provide the room and board, the housekeeping, the laundry, and the nursing care, and the staff that he has had for the last few years and has gotten comfortable with.
Yeah.
When hospice comes in, it allows them to take care of him in that setting, but it also allows us the opportunity to come in with the extra symptom management, the extra support, because they've gotten attached to your father also. So we can support them on their journey as they watch him decline and go through the stages that he will go through And so we try to bring support to both entities. Many staff in the long-term setting are not as comfortable with death and dying.
What about family members?
And for family members also. So we get the benefit of not only working with your father, but we get the benefit of working with the long-term care staff and the families, and pulling everyone together so that we're on the same page, what's in his best interest, as well as how can we be there to support you. Sometimes it's visits. We coordinate visits so that everyone gets to the nursing home at the same time. We've had some families that we've met them in their home and allowed them a private time to breathe and to talk about what's going on. We've also met in care plan meetings where the nursing home staff, you as a family, hospice sits in, and we again just make sure that we've got the right medicines, the right support, and everything that's on board for him.
And so you're saying these are all things that as it stands now, he wouldn't be getting and does need to get. Does that make sense to you?
Hospice
it's the end of life issue that hospice deals with.
Yes,
okay.
Hospice is a benefit that many people don't recognize is in their Medicare Part A. And this is it covers everything that we provide. The only thing it does not provide is medications that's not related to the hospice diagnosis. And Dr. Grumbles would be able to, again, be the guide on the medications, what he needs now, maybe medicines that's not necessarily needed at this time in his life. But again, she would be reviewing our plan of care every couple of weeks and making sure that we're on board for him.
So basically, Medicaid and his insurance is going to pay for the hospice care.
Medicare.
Sorry.
We will not need to bill the Medicaid.
Well, that sounds pretty amazing, actually.
It is. It's very good. It's one of the few parts of Medicare that will cover the medications. Some part of the medications, we cover the medical equipment, such as, again, the oxygen, the electric bed. We also help provide medical supplies, the diapers, chucks, those types of items.
So what do we need to do?
You would need to complete our consents. You would need to let Dr. Grumbles know that your wishes would be to proceed with hospice. And as soon as she gives us the order, then we would be able to admit your father under our services, and we'll have a nurse come out and assess him.
Okay.
Any other questions?
I think that makes a lot of sense, actually.
For now? No, but there'll be some.
And you will have a number that you can call us 24 hours a day. We will respond, and there's no question too small. So we recognize this is a tough journey, and you're welcome to call anytime. And I'll give you my card.
Thank you very much.
Thank you.
It felt like you wanted that back.
Yeah, I really did.
Well. Excuse me.
You okay?
I'm fine.
Yeah, I'm gonna wrangle the doctors here.
They're like, wow, we're worried about that cough. It's
just swine flu. Okay. Well, let's just take a second. Deborah, how did you feel about the encounter?
I expected them to be maybe just a tiny bit more emotional, but that's all right. Because I've met people at various degrees and stages. You were more prepared than some people, some families.
Well, as a role was, we were going from the shoulder all the way on. So
we were kind of prepared for the fact that he was.
Yeah, that's our role. That was a role.
And that made it a little bit easier.
Yeah, I guess it does.
And have y'all ever personally experienced having a loved one in hospice before?
No,
or
not
a
in
husband?
hospice, no.
Okay.
Mine have died.
Did they die in hospice?
No,
Did they have hospice
Did they die? Okay. Well, did you feel like the information that Ms. Perryman gave you, did you feel like you were very understanding, you have a better comprehension now about what hospice is?
It's almost like I can't believe that's what hospice is. That's what I'm like, really? Medicare pays for it and they get extra? I don't see a reason not to do that. It was really interesting, actually.
Good. Very good. Do we have any questions from any of the sites?
Hello.
Yes, Dr. Vogelpool?
If patients are worried about running out of money, there's some, if they use up the money, like if the roof needs repaired, you can go ahead and repair the roof. And if you run out of money, Medicaid will kick in. And that's what some of my patients have done. They've used up the money or doing some things like repairing the roof, which is very legitimate. It's a legitimate thing. And if they realize that, then as Medicaid kicks in to back up, so they won't be out on the street.
And when we wrote the scenario, that's how we wrote this in, is that between that first role play and then the second role play, and then between that second one here, that's what they did. They spent down, made him where he qualified for Medicaid so that it wouldn't be a lifelong financial burden on the family. It was just a short-term burden until he could spend down and qualify. So that's exactly what we saw would be the common scenario. So thank you for recognizing that and bringing it up.
I've practiced for 55 years, and I gave very strong support to the social work and physiotherapy, occupational therapy. You do what you need to do, call the family, do anything that you think is appropriate to have my patient.
Yes. Yes, Dr. Vogelpool for a long time believed in interprofessional teamwork before it became a buzzword in the healthcare community. So we have to give him credit for that over the years. Any questions from anyone here in Galveston?
Dr. Melvin, patients just on Medicaid. Does Medicaid pay for hospice?
Yes. In some instances it will.
Can you repeat the question?
Yeah. One of the geriatric fellows here is asking if the patient does not have Medicare and they only have Medicaid, will Medicaid reimburse for hospice care? And Ms. Perryman says they definitely do. It is covered.
For information, could you bring up the scenario when there was a turnaround and the patient improved so that the life was extended beyond the 6 months? What happens then?
I can tell you that one because that's my job. I frequently, with the diagnosis of congestive heart failure, end-stage heart disease, congestive heart failure, I frequently have patients that are referred to hospice that are in and out of the hospital every 4 to 6 weeks. And the hospital says they're end-stage. Well, essentially, I put them in a heart failure clinic when I admit them to hospice because I have a nurse going out every week and making sure they get their medicines. And because ischemic heart disease and stage heart disease is their diagnosis, the hospice Medicare benefit pays for the medications. I have a scale so that we're weighing the patients every day so that we can titrate our diuretics. So essentially they're placed in an intensive heart failure clinic situation when they move into hospice. And I have had people that after 6, 8, 12 months, they may have an ejection fraction of 10%, but they have not had an exacerbation of symptoms, and they have not had any need for medication changes or for any trips to the hospital if we had chose to do that. So in that case, sometimes what I do is I prep the family when they come in with these diagnoses that I'm not sure. My crystal ball isn't as clear as with cancer that this is truly terminal in the next few months. And I tell them, I'm going to watch your loved one. And if your loved one stabilizes and gets better, I'm going to graduate them out of hospice. And after they graduate out of hospice, then your doctor will assume their care again and will watch them. And when they deteriorate to the point that they are now deteriorating instead of being stable, then all they have to do is call me and I readmit them right back into hospice. And there's no financial penalty. There's no problem with anything at all. So I graduate people out of hospice when they get too stable to remain in under criteria. Any questions from any of our other sites? Okay, well, I want to thank the standardized patients. They did a wonderful job. Okay. And I also want to give a special thanks to Deborah Perryman and to Lisa Ballard for their wonderful skills. Like I said, I put them in here cold. I didn't give them a lot of information about the patient. So they actually showed y'all the great job that they can do every day with patients, not a scripted job, but a good job that they do naturally every day. So now what I'd like to do is just step back for just a few minutes and talk a little bit in wrapping up about what we've learned today. Okay? We definitely know that there's a mnemonic out there for you that are educators with novice learners to try to help you, assist you with teaching the skill of delivering bad news. And you're more than welcome to use the DVD in any educational arena that you wish. If you need to make copies of the mnemonic card, that's totally at y'all's discretion to copy and use that. We really want to help, if we can, with the communication skill education. The other thing, though, I think is important is that we've now learned that there are a lot of bad news scenarios in geriatrics, and they're not always related to the end of life. So pretty much most of what we do in geriatrics, in one way or the other, frequently involves delivering bad news to our elder. Because inherent to our population of patients, they're going to lose functionality. They're going to lose cognitive ability. They're going to lose their independence. And all of those things are travels down the road of intermittent having to deliver bad news. So we need to realize that we need to use the principles of empathy and compassion regardless of what we're telling our elders, because at any time and moment it may be a bad news encounter to them, even if we didn't, as healthcare professionals, consider it a bad news encounter. The last thing that I would like to kind of wrap up and make sure that everyone is aware of is that empathy is the most important part of patient and provider interaction. It's not what we said. I could have sat up here and told this family, I know nothing about options. I know nothing about options. I've got to get you to somebody else. And it wouldn't have made any difference if the family felt like I was empathetic to their plight and their concerns, and I recognized their feelings and I validated their feelings. So it's very, very important to understand that regardless of what part we play in the communication and the delivery of information, that we put empathy as high up as we can. We don't just say, I can't help you, I don't know, let me get you to someone that can. That's a very nice assistance that you're providing them to get them to some help. But what that family needs when you're delivering bad news is they need the empathetic support. It's much, much more important than the actual information, the data, the information, the options that you're providing. So even if you don't know what your options and information and data is, provide the empathetic support to your patient and then facilitate them getting to the appropriate healthcare professional that can help them with their area of delivering bad news, whatever the next step is in the process. That kind of wraps it up from my standpoint. Now I'd like to see if anyone has any questions or any comments that they'd like to make about today's seminar.
I remained the PCP and my patient and Dr. Grumbles was the consultant, and that's another way. This is the way I practice. And she was a consultant, and whatever she wanted, she had unlimited, whatever she wanted to do, she could write the orders, and the nurse would call me and I'd approve. That worked very well.
Yeah, we do that a lot in hospice, where the hospice medical director and the attending from the nursing home or the PCP from the clinic, we work together as a team. The physicians work together to try to coordinate and provide the care. And it always works very nicely when you have a good working relationship, the way Dr. Vogelpool and I do, where we feel comfortable talking to each other and calling each other and discussing the patients. It works in the physician's best interest and the patient's best interest. Yes, ma'am?
How would we get a copy of the DVD?
I can get you one before you leave today. The DVD was prepared by a grant through Arthur Vining Davis, who's a foundation that works on trying to increase and promote the care of patients, usually in terminal states of their life, and they provided the DVDs at no cost through the grant. So thanks to them, you can have your own copy. Anything else?
I wanted to bring, it's interesting that when Lee first brought this up in terms of how she was going to do the program today, she talked a lot about the speak mnemonic. And when I'm thinking that health literacy has its own speak mnemonic, if we remember that. Remember, speech, perception, education, access, and knowledge. And I was trying to figure out how is that going to be put into the Breaking the Bad News, realizing then later on that they had their own mnemonic in terms of what that was described. So it's easy to get these confused, but I think it was really clear with the descriptions and having the video in terms of how it's used for the Breaking the Bad News. I think it was really well done.
And I know this was supposed to be a health literacy exercise, but I can tell you, if you don't have the communication skill to communicate something as far as evaluation or communicating information, you're not going to be able to address the health literacy issues with patients and clients. So we felt like looking at communication was very, very important as our first step in getting comfortable with healthcare literacy.